Thanks everyone, and welcome to Trauma Module 3 on fracture-related infection. This is our third in a series of three. We previously had the Journal Club and we had the webinar, and tonight we're having the Fireside case discussion. So we have Dr. Stephen Warner from UT Houston and Marshall Burks back with us this evening. I'm Josh Gary from University of Southern California. Here's Dr. Burks from WashU in St. Louis and Steve Warner from UT Houston. Here are our disclosures. AO North America's independent nonprofit surgical specialty society dedicated to improving care in patients with musculoskeletal injuries, and it does not endorse nor promote the use of any product or service of commercial entities. The equipment used tonight, you'll see in these presentations, is for demonstration and teaching purposes with intent to enhance the learning experience. In this fireside chat, we'll have case discussions. We'll discuss them amongst us. Please send in your questions. We'll have cases that will reflect some different areas of prevention, diagnosis, treatment, management strategies. At the end of this session, we want you to be able to understand modern best practices to prevent development of fracture-related infections, to understand diagnostic tools, including imaging and lab values, and appropriate indications for their use, and to learn surgical management techniques for bone and soft tissues associated with fracture-related infections. So here's our agenda tonight. We will be able to get started with cases just a little bit earlier to preserve more time for that. We'll have 3 case presentations and then come back for more questions and discussion at the end. But please have your questions coming in as the cases go, and we may try to answer some between the cases. So let me just move over to case 1. All right, so case 1 tonight on fracture-related infections. So Dr. Warner and Dr. Burks, I've got a 29-year-old male. He's been in a high-speed motor vehicle collision. He had several injuries, including an intracranial injury. He's got a severe injury to his left eye. He's got pulses present in his right lower extremity and a large open wound. We did not have injury films as he was whisked away to CT, and we just have a splint AP here. We've got a lateral as well, but you can see the wound there on presentation. You can get a little bit of the indication of the injury to the right lower extremity, and there's nothing above this ipsilaterally on the leg. Any immediate thoughts on here we are with this guy presenting? He's got a head injury. We don't know when he's going to be cleared for the OR, but not cleared right now. And here's what we have.
Yeah, I think overall thoughts with this patient and his injury are thinking about the life limb function priorities. So with his intracranial injury, that's going to take priority, I think, over this open lower extremity injury. But once that is stabilized and I think he's deemed to be a candidate for the operating room, going to the OR for urgent debridement and irrigation is important. I think while he's being evaluated in the emergency room, prompt antibiotics are important. Yeah, I think the debridement of this open wound is going to be really the key, as well as early antibiotics.
The is that wound kind of like anterolateral?
Yeah, that's lateral and anterior lateral. That's the anterior compartment you see at the most anterior portion of that wound.
Yeah, it's a bit unusual in terms of its location, but these come in all sorts of flavors, I suppose. Yeah, the only other thing I would say about the head injury piece is you might be stuck for days or longer trying to take care of this thing. At least that's been my experience, depending on the severity of it. So sometimes, like, being able to get in under the gun before everybody kind of knows what's going on. Not that I'm advocating for unsafe practices here, but pouncing on an opportunity when you got one, especially if he's going to the OR for another reason, for the head, for instance. So never missing an opportunity, but that looks like a pretty nasty wound.
Yeah, and they weren't taking him for his head. It was monitoring in the ICU with serial CTs, didn't have intracranial pressures. But let's say he didn't have that, or when does this become a night of or day of case? And at what time do you say, let's put it on first case in the morning?
Yeah, I don't, I guess I'm more on the aggressive side of the spectrum, kind of, golden rule type stuff, even though I would say there's not a lot of strong data to support it. But sooner is better. You got to take into account, kind of all the system factors and, frankly, like what is the OR? Is there a bunch of hot bellies that are laying around bumping you? And are we coming up at 3 or 4 in the morning? And now it's just like, okay, let's just do it in the trauma room at 7:30 a.m. But I would lean towards being a bit more aggressive with an open P-line like this.
So 10 p.m. or either of y'all, if it's 10 and they're there and they say they're clear, are you taking it up at 11 or midnight?
Probably.
Yeah, I'd probably put on for a first start the next day, because 10 p.m. turns to 12 p.m. turns to 1 p.m. 1 a.m. once they get to holding and the team gets assembled and all that. And I think having kind of your orthopedic team and the efficiency that they have is important. That being said, we all know that cases can continue to stack up overnight, and so if it's looking like cases are stacking up with other, fractures and injuries that need to go the next day, then that would push me more towards taking it kind of the 10 p.m. hour.
Yeah, I mean, I think for me, if this is coming in and I mean, even 6, 7 p.m. and I can get up there and get started by 8 or 9, it's one thing to get a wash. If we're starting at midnight and going to be going from midnight to 2 or 3, I don't know if that 7 hours makes a difference. And I think I'm probably better. And I know my OR team's typically better at 7:30 a.m. For what we need to do. So he didn't clear till hospital day 2. And so, I was planning debridement irrigation and X-Fix. I guess we can show exactly what I did day 1, but what are your thoughts, Dr. Warner and Burks? Are you doing anything else on day 1? And this has been now about 36, 40 hours since injury when he's cleared to go to the operating room.
Yeah, we have a little bit of clue, I think, in terms of what you did, but I like where kind of this is heading. I think, without seeing any sort of cross-sectional imaging like a CT scan, it seems like there may be a relatively simple fracture planes, that you could potentially perform some kind of initial reductions and fixation for, along with some sort of spanning external fixator. But if there are simple fracture lines, especially that you can see in through the wound, or, for example, if there's some posterior medial extension there, that you can make a limited posterior medial approach and really get that apex reduced to the intact proximal shaft and initially stabilized with some independent screws. I think that can be really helpful for his overall kind of longer term alignment and prognosis. So I think kind of some, limited amount of reduction and stabilization like you have here is important. That being said, not doing the full definitive fixation, considering the open wound and the need most likely for some sort of soft tissue coverage, and trying to minimize the time interval between definitive fixation and soft tissue coverage.
Yeah, I like that. I mean, it's all situationally dependent how contaminated, how dirty is it? Does it is this going to be multiple debridements type thing? How much bone are you going to be yanking out? Some of that stuff you don't know until you're in there in the heat of battle. So, but what I think is happening here, maybe you can do some fixation of the fibula just for some added stability potentially, and then like Steve was saying, some of these larger metaphyseal chunks might be an opportunity.
Yeah, so I mean, I think if we have I'm not going to extend incisions and traumatic wounds in this setting to do this. I think applying clamps percutaneously, or as we did here, just through the large 3B open wound, taking advantage of simple reads. Yeah, even when you put a frame on, it allows you, as you tighten up your bars, if you have the clamps on, I think it tends to hold better reduction. Whereas you try to get the reduction pull and tighten things up, it always seems to move around. If you can clamp it through open wounds and then get your frame on and set up, it seems to hold a little bit better when things are tightened up. And so here we felt like we didn't have everything. We didn't have a CT yet, but just the clamps to hold it. We put an ankle spanning frame on. We did a cannulated screw to restore the joint. Tried to realign the fibula. I think we were thinking about where you were going, Dr. Burks, with some kind of stabilization. But you can see that was unstable, but put a wound back on because we knew this was going to be multiple debridements. At our place with plastics, you're usually looking at least 5 to 7 days, or sometimes 5 to 14, depending on their schedule and OR availability. But this is where we had him after night 1 with a wound back in place.
Josh, there's a question in the Q&A box about the two calcaneus pins. So maybe, and you can see a nice clinical picture of that there. Maybe discuss a bit kind of the value that you have of using two calcaneal pins in this situation.
Yeah, so for me, I learned this from I think Burgess and the shock trauma crew way back in the day were doing this. I think the advantage is you get control of the hind foot with two pins. Frames tend to be more durable, and here you can see a 4 foot pin as well. But when you put this type of frame on, the 4 foot is not rotating around a single pin. Now people will put a splint on to try to prevent it, but we all know we see those one pin X fixes, and people say the pin craps out or gets infected or is soupy. Well, that's because the soft tissues are moving around it. So for this C-type injury, I prefer two pins. I think the other thing is if I am thinking about plating, this becomes an indirect reduction aid. So I can take the 4 foot pin out, and if I'm going to do an anterior lateral approach, this lateral bar can slide right off. And then I've got largely my reduction held by the medial bar. If I'm coming anterior medial, I can take the medial bar off, leave the lateral on. So this is just this frame, while more expensive than some of the other frames that are out there, it is trying to help set me up for definitive fixation with plates if I want. But I also feel that by stabilizing the soft tissues and preventing movement around the pins are a lot more durable, especially in a 3B situation.
Yeah, I like that clinical image as well because you can see from the x-rays of all the clamps you had on there to do that provisional reduction, you can see the resultant soft tissue, insult to that is very much, it looks like what the injury kind of clinical picture looks like. So just using what you have through that open wound gave you a really nice reduction. And then even that percutaneous screw there, you can see that minimal kind of additional soft tissue injury.
Yeah, and so here's where we were, and I mean we'll have the CT scans here that you can go through. And I believe this was on about a Monday, and Plastics said next Wednesday was their flap time when they had a room, which is probably a reality a lot of places. But here was our alignment initially in the frame.
Just a question, Josh. Any adjuncts did you use at the time of the debridement? Powders or bead pouches, or what's your
I
typical
know
go-to?
there's a randomized study going on right now, but when we were in Metric at UT Houston and we had the great uh, since passed Manny Melisnos as a plastic surgeon, we weren't doing these bead pouches or any of these things, and we were putting on wound vacs and doing excellent debridement with our knives back to healthy bleeding tissue. And they didn't believe us on the complication rates. Now that said, I will say that even with Dr. Melisnos there, when we early on looked at 3B and 3C pelons that got plates, it was a 67% infection rate. We presented that at the academy, actually submitted it to JOT and did a full boat of revisions, and then they decided not to publish it because I don't think they liked the message that 2/3 of these that were 3B got infected with plates in them. So that was, but it's some of the other studies we weren't, and maybe they're adjuncts we can use, but I hate bead pouches, and I know they may be good, but they just leak on the floor. Nurses call when you take them off. The milieu just looks gross to me, and maybe that's just my bias. But I think wound vacs tend to work well, but I know that's debatable. I don't know. What are y'all doing at your centers now?
Mostly wound vac. Kind of
Same.
when I think of doing a bead pouch, which is not all the time, I'm not wholly against it, but I hear what you're saying. I am intrigued by some of the newer stuff or piqued interest, but it just does look like a kind of a protein soup of sorts.
Yeah, and we'll see. And I know University of Utah and Lucas Marchand has a randomized study going. Hopefully, it will shed some light. I think a lot of the data from that came back from the military and some of the in vitro studies. But so here we are. So the free tissue transfer is planned for Wednesday. They get an interval IND and wound vac exchange where things look clean, and they're Plastics is planning an ALT from the ipsilateral thigh. So what are y'all thinking on timing? What are you thinking on next steps? How are you thinking about managing this?
And this is a week from now, the Wednesday.
Yeah, let's say he's had that on Monday. He's going to get a repeat IND at about 72 hours Thursday or Friday. And
Yeah.
then some other plan, but that's what we have.
Yeah. So I think, yeah, I plan for fixation, probably Monday or Tuesday of that week before he gets his free tissue transfer. So try to minimize that time interval as much as possible. During the interval debridements, I may also think about potentially stabilizing the fibula through that open wound as well, just to provide additional stability and keep the length of the fibula before getting too short. Um, but otherwise, I think I'd plan for the definitive fixation probably Monday or Tuesday of that week. In terms of what to do, I'd have to study a little bit more, but I think, was your sense from the soft tissue wound that that lateral wound was all a tension failure from the
I
initial
felt
injury?
I felt it was more of a, there may have been a little tension, but really more of an axial explosion. Like if you step on a jelly donut and the jelly comes out, I felt like the jelly came out there somewhat with somewhat of a coronal plane tension.
I think from an articular standpoint, you had a really nice initial reduction of that main articular fragment. The medial malleolus is still need to be addressed, and so I'd probably be looking at an intermedial approach for the main working approach for the distal tibia to be able to see that metaphyseal reduction as well as the medial malleolus reduction there. And then in terms of plate application, I don't love an anterolateral plate for this because of that open wound there. But that's probably what I would consider as opposed to a medial plate. So probably anterolateral plate, independent, medial column screws from the medial malleolus into that intact proximal tibia, and then probably an intramedullary implant for the fibula.
Yeah, I think it's I mean you could do a variety of different things. I mean, heck, you could treat this semi-definitively with an X-fix if you were really concerned about it, and just write it off some limited articular fixation and prove itself aseptic over time. Not that I would expect the metaphysis to heal in a frame necessarily, but I think the pieces are big enough. You could consider some intramedullary stabilization if you're looking to avoid surface implants, if you think that makes a difference. I just kind of like the centrally placed implant and the mechanical benefits of that. I would say I would be checking pretty closely about the syndesmosis stability. I don't know if that's something off the anterolateral aspect of the fibula, but when it's all said and done, I would be sure to check that too.
Yeah, I think those are all good points. I think, that study I talked about that never got published but presented, has really influenced me. And so we came back the day before coverage and augmented the articular fixation through limited approaches, reduced the medial malleolar component, stabilized it with fully threaded screws once it had been reduced with clamps, and then did what y'all said on the fibular side, creating stability there, just opening with a 4-5 drill bit, and then open reduction through that large wound and a flexible nail. I always tend to leave those proud in case I need to retrieve them in the future. And here was his alignment, and we planned on leaving him in the frame, at least for the time being, to minimize surface implants. Now, that said, you can see we had our frame set up so that plastics could take off that lateral bar, and we actually assisted them with that the next day. But here is the day before coverage. You can see a little bit of sagittal plane translation.
Josh, just real quick on this frame, once you decide to do definitive frame fixation, I know you set up your frame in case you're going to do some other type of plate and screw fixation, so your pins are remote from your plate and screws. But in this, do you at all consider kind of maybe putting another pin closer to the fracture, so more on the distal tibia to help maximize stability of this?
I think you're exactly, because you can see this is the day before coverage. And then even with our team taking off the frame and replacing it, there was some loss of reduction after the frame. And we noticed that almost immediately, and they didn't feel we could go back. So yes, Steve, you can add pins. It's not always in the perfect vector, but if you have it clamped, you can add them off the bars. And I wish we'd have done that here. because I felt like we were letting the flap heal, and then we could come back once the flap had healed and taken at a later time and decide if we were going to do some nippo type plating on the medial surface. But now we've got this situation 6 weeks later. So we're getting to time a little bit on this, but I won't belabor it. But here we had taken care of, like you said, life limb function. We now have a free flap that's healing well. The pins all look great at this point, but it's 6 weeks later. So we gave him a pin site holiday, and we wanted to see if this was how mobile it was, to see if we could do anything percutaneous. We didn't feel that we could. So this is more than 6 weeks. So using Pete Nowatarski's old article out of Shock Trauma about converting tibias, you want to do that within 3 weeks if you're going to convert to a nail. And then 8 weeks post injury, we came back and did a small posterior medial approach. Again, we cleaned the area on the tibia, clamped it, and then we placed a medullary nail for the metaphyseal portion of this injury. And you can see final alignment there. So trying to avoid surface implants, letting the flap heal, not being in a rush. Here he is at 10 weeks post-operatively. We had him weight bearing in a boot at this point because we felt the articular surface was healing well. And he had a medullary nail now, pain's improving. Here he is 10 months post-injury, walking in a normal shoe, not yet running, but no pain. And we did remove his flexible nail in the fibula as it was a little bothersome to his peroneal tendons. Here you can see some clinical imaging and a clinical video just of the result with the ALT free flap and no pus as of yet. But I think what went well in this and preventing FRI, it was debridement as soon as we could. I don't think that has to go in the middle of the night, but excellent debridement when we got to go. A durable external fixator construct, although we did lose some reduction. I feel like avoiding the surface implants early on, especially in these 3B pilons, is critical. And then I think the patients to know we can come back and reduce things and get metaphyseal reductions even in a delayed fashion with good technique. Great, Dr. Warner Burks. Any other comments on that case? And I'll stop sharing and let Dr. Burks bring his up.
No, I think the thoughtful plan with those, no matter what you do, is really important. Know what your next step is going to be because all these sequences take kind of thoughtful consideration in regards to the next step of what you're going to do. So I think just know your plan from the beginning and kind of set yourself up like you did.
All right.
Never out of the woods with pus.
Do you want me to go or Dr.
I have
Warner?
Warner. I had Dr. Warner second. Yeah, Steve, you want to go
Okay.
second?
Yeah, stay on the algorithm.
STW.
Alrighty, getting on to the next case. So kind of moving up the tibia a bit. So this is a 14-year-old male after an ATV accident. He comes in with a 3 centimeter open wound on the medial aspect of the leg with some contamination from the accident. He was initially treated outside hospital with this provisional external fixator, as we can see here, and you can see the shadow of a wound vac applied to where that open wound was. And then 3 days later, went for removal of the X-fix and conversion to an intramedullary nail, and then closure of the traumatic wound. And so here he is at 2 months, kind of showing really no progression of healing, but maintained alignment and fixation. Here he is at 3 months, and then here he is at 5 months. And at this point, he's referred by the initial surgeon for further evaluation. So this is where I kind of met the patient at this 5 month mark here.
Referred because the bone wasn't healing, or there was kind of more than that.
Yeah, referred for the kind of bone not healing, as well as he started to have some intermittent drainage from this medial traumatic wound over the mid leg. So they
I was
only,
wondering if this was Gorham's disease because I see disappearing bone. But don't for all the participants, it's almost always pus. I don't know that I've ever actually seen Gorham's disease.
yeah. So along those lines, Josh, with this radiographic appearance, knowing the history, maybe something on the physical exam of that drainage there, what are your thoughts?
I mean, even if he weren't draining and I saw this X-ray, this would be pus. It'd be PID or pus in there. Just this screams pus. It was an open wound. I don't know it sounds like they were able to close it, which I do like their stage management early on if they felt they needed to. But once this is pus, and here you see if you look at the serial radiographs, we're not seeing any progress towards healing, which to me tells me the pus is winning and taking away bone through all the mechanisms, bacteria, and whatever other pus causers like fungus or anything else could be due. So I think the nail needs to come out. I think you've got to look at the wound and see if he needs debridement of the wound on the extra or on the surface of the bone, or whether you're just going to take this rod out and then think about something like a saucerization of the canal with a rhea and an antibiotic nail with cultures and see what's growing and see if you can get things to get the infection under control, get a diagnosis, get culture specific antibiotics, and start seeing if the you can stop the bone from disappearing and get some bone to start progressing towards healing.
Was the drainage in line with the closed traumatic wound, or
Yeah.
was it, from interlock side or somewhere else that
No, just the medial traumatic mid-leg wound. It's kind of a 3 centimeter open wound. So there's just a, small amount of kind of serous looking drainage from that area.
Okay. All right. Yeah. I mean, obviously concerning. This is not something to go ostrich mode here and put him on antibiotics. You got, as Dr. Gary pointed out, X-ray findings that are extremely suspicious for this fracture site just being infected with resorption. Started out a little distracted, but this is something beyond that. So I would want to be pretty aggressive in terms of determining viability of the fracture site, the bone ends. Like, how did it start out? Were these totally stripped and necrotic? And then I think the soft tissue problem is going to evolve as well. Like, I don't know anything about the patient, what the exam is in person, but this is probably something that's going to evolve into requiring multiple debridements, removal of the implants, probably some kind of soft tissue coverage reconstruction after the infection is under control. And I would also say there's probably, be prepared for a resultant bone defect would be on the table here.
Steve,
Yeah.
Stephen Marshall. There's one other question in the chat, just briefly, and we can talk about the last case and touch on it here. They ask about the use of ring external fixators definitively. Are there any things that help guide you guys on when you'd consider that for any wounds? I definitely think it could have been considered in that 3B pilon if you fix the joint and then used a ring for the metaphysis.
Yeah, I think the Fix It trial, I think, was helpful to kind of look at the outcomes of these types of injuries with, internal fixation versus external fixation in general. Showed some improved outcomes with internal fixation. So from an acute standpoint, I typically rely on internal fixation, and even for reconstructive procedures, I do think internal fixation with the tools that we have now can be very beneficial. The setting of a severe infection, I think, maybe gives you pause for considering other options other than internal fixation for those cases. But in general, I rely pretty heavy on internal fixation.
I think your case probably nicely illustrated the benefit of converting it to like a multiplanar external fixator or circular or whatever, what have you, to just help kind of better maintain that metaphyseal alignment if you're expecting this thing to hang on for some period of time. So that's at least for me when I would think about that, rather than expecting some more simple frame to do the job over a period of 6, 8, 12, whatever, how many weeks.
Yep. So
I have a
Steve, what were
question.
you asking here? Sorry.
Yeah, I have a question for you guys. So this is at 5 months, but let's say, this patient with the same history comes back 2 weeks out with draining wound, concern for infection. Um, Something that needs to go to the operating room for debridement irrigation. Let's say he has a breakdown of his traumatic wound, or he has a free flap that has, drainage coming from out underneath it. In terms of nail retention or nail removal, does that make a difference? Both of you guys said nail removal for this, kind of 5 months out with kind of seemingly progressive infection, but let's say an acute fracture-related infection with an intramedullary implant. What are you doing with that?
Think if the implants are stable and I don't see bone that's either changing its appearance or having the appearance of, sometimes you'll see just cortical erosion. But if I'm seeing any difference in the bone and it's looking worse and not better, I'm probably, I'm going to remove the implant, or if the implants have lost stability and aren't maintaining reduction, they're coming out. That said, if it's just a wound breakdown or the wound hasn't taken or the flap issue, it's likely going to be debridement. It's going to be more of a DARE type procedure, debridement, culture specific antibiotics, and retention.
Yeah, I would agree with that for the most part. Some of that may be hopeful too, but if it's frank purulence, I mean, that's one thing. I would be less enthusiastic about keeping something, even if it was only 2, 3 weeks. But if it looked totally nasty, I wouldn't be less optimistic about that being successful and not having biofilm set up in the intramedullary space, et cetera.
So just a couple of quick slides on some of the literature for diagnosis of a fracture-related infection, especially with non-union. So in this case, you have a draining wound, which definitely pushes you more towards that infection as well as that radiographic appearance. But in general, I think some of the literature can be helpful to determine when a non-union is a fracture-related infection. And so this was a study from 2013 looking at some of the different markers of infection preoperatively, really showing that CRP and ESR can be helpful in this regard. And then when you combine some of these positive tests, the more that you get in theory regarding the predictive probability of infection, the higher the consistency was. There have been a few more recent studies which kind of have challenged this, looking at biomarkers for fracture-related infections. Those are the 106 patients out of the UK. And they used the FRI consensus definition, and they did not really show any correlation of these serum markers of CRP or white blood cell count with infection diagnoses. And then similarly, this paper from 2021 also showed a similar result with over 200 patients with suspected septic non-unions. And again, no more correlation between the serum inflammatory markers with predicting infection. So it's just something to keep in mind. While these can be guides, I think you have to use a whole clinical picture, as Dr. Burks and Dr. Gary did, with the history and the physical exam, the radiographs, and so forth. So while serum markers can be helpful, I think you have to take in the whole clinical picture. Do you guys have anything else to add on kind of using these lab markers for diagnosing infection?
No, I mean, I think he highlights the concept. These are suggestive; they're not definitive um, criteria for infection, right? And then, if I'm remembering correctly, I think the Tornetta study, even if all three of them were normal, that at least in their series, it was 80% were there were 20% that were still infected. So, just because they're positive doesn't mean they're affected. Just because they're all negative doesn't mean they're not. So you could look at it either way.
Yep.
I mean, they're not, none of them are specific. I think if you fart, your ESR probably goes up if you have flatulence, but I use them more in the setting of once we have an infection, if they're high, how is the infection responding to our treatments with surgical and medical management? And I do think they can be helpful in diagnosis, but if I've got a draining wound and everything's normal, I'm going to be thinking that's infection unless I've done something like calcium sulfate beads or something that just doesn't make sense and is going to confuse the picture. So I'd recommend folks stay away from those things that cause drainage that may not be infection. That's not fun stuff to not fun questions to try to answer.
Awesome. So yeah, I think with everything that you guys mentioned, presume that this was an infected non-union. I think all these kind of discussion points we kind of mentioned about whether or not to retain the nail, how to do the debridement, what your margins would be, how much you debride, how do you stage this, and then what kind of provisional fixation we can use. And so similar to what was suggested by the other panelists, took out the intramedullary nail, did a local debridement, so extended the medial wound and coordinated that with plastic surgery for soft tissue coverage. I think that team approach, as we mentioned, the first case is really important. Adequate soft tissue coverage can be critical for successful treatment of these injuries. And then also, I think Dr. Gary mentioned this, but intramedullary debridement, I think as well is really critical, especially when you have that implant in place to minimize the residual infection in the canal. And so this was the provisional stabilization. This is just one option for what you can do. This is a ball-tip guide wire that's coated with antibiotic-containing cement. And then just to help control some rotational and axial stability using a two-pin external fixator, just to minimize any other screw holes you may have from an antibiotic-coated locked nail, for example, and still provide some stability to the tibia as well as to the soft tissues.
Steve, just quick question for international participants who may not have the reamer irrigator aspirator. How would you recommend they do medullary debridement?
Yeah, so I would, and I'll still do this sometimes, depending on the severity of the infection. If I think I can just sequentially ream like I would for a nail, make sure I have good endosteal contact of the upper size reamers to debride the canal, and then just use cysto tubing down the canal, and then you can place that into the canal all the way down to the distal tibia and make sure you have egress of fluid coming out through the wound, so you know you have a portal for the fluid to escape. But that's just a simple way to perform intramedullary debridement and then subsequent irrigation. But I don't know, any other tips that you guys have?
That sounds good.
Yeah, just, I mean, sometimes you can vent distally too, and just make sure that you're able to push the reamings out if you don't have something like a reamer irrigator aspirator.
Yeah.
The canal brushes, well, that's probably going to be a North American or first world thing where you have some of the brushes that go down the canal on the jet lavage, but that's not always available everywhere.
Yeah, so just moving forward with this, along the lines of, making antibiotic-coated implants, there's a few kind of papers that you can go to for some tips on that. So this is one paper by Dr. Sirkin from a couple years ago, kind of goes into making some temporary antibiotic-coated rods that you can use for treatment of infection. And then just regards to making an antibiotic spacer for bone defects in case of an infection, you can see here using the PMMA cement along with methylene blue, which helps you really differentiate the cement from the surrounding white bone. And then you just want to make sure that you make the cement in a similar shape as the bone that you're going to be regrowing in some way in the future, as well as overlapping the bone ends as well, especially when you're going to be doing some sort of second stage mascellate. So here's his cultures, Enterobacter,
Mm.
Pneumonas, and Clostridium, which are none of which are really favorable organisms, but just information to have. I don't know if does this influence you all in terms of the types of bacteria that are causing the fracture-related infection?
They're just, yeah, gram negative. I can't remember all of them, but it looks like a mixture and a polyflora. It got to get it clean, get all the metal out, and see if you can get things to heal. I know that people feel some bugs do worse than others, but now this is really about sterilizing this bone, making sure all the dead bone's gone, and giving yourself enough time and enough treatment to try to clear the infection if we think the infection ever gets cleared, or at least really put it into senescence.
Yeah, I think.
Yeah.
Go ahead, Marshall.
No, I was just going to say, I mean, to me, this is a bit worrisome and would, if you were perhaps a little less aggressive on the front end, maybe think about, okay, going back, doing more debridements, resecting more bone if you're kind of unsure. These are a bit unusual, maybe speaks to the amount of contamination or what the original open scenario was in the first place.
Yeah, I think this is also just a plug for the team sport of treating these types of injuries, and people with a background in infectious disease can be really helpful and have thought a lot more about how to treat these various organisms. So definitely a helpful resource. And so, as you move forward with definitive treatment for this, a lot of things to think about in terms of serial debridements, and then in terms of what you do with the bone defect, especially with regards to infection. I think you have, as we mentioned, kind of internal and external fixer options, and then kind of timing of all this as well. And so, for the sake of time, kind of move forward with what was done. So I waited 6 weeks just to help treat with some appropriate antibiotics. And then I did an antibiotic intramedullary nail exchange and took additional cultures before moving forward with the reconstructive steps just to make sure that from a cultural standpoint, the infections seem to be under control. And then went forward with the emasculate technique, did an intramedullary nail of the tibia, harvested bone graft from the ipsilateral femur, and then grafted the defect as shown here. So here is at 2 weeks and then 3 months, just showing some starting consolidation of the bone graft. And then here is at 1 year and 2 years with full consolidation and healed wound and overall functionally doing very well. So I think just looking at progression here, again, I think a couple of the take-home points for this is maintaining a high index of suspicion for fracture-related infection. We talked about the aggressive debridement for something like this, both the local debridement at the site of the fracture as well as the intramedullary debridement, considering they had an intramedullary nail. And then the team approach is really helpful, especially the plastic surgeons and the infectious disease colleagues you work with.
Great question in the Q&A that I was going to ask, but how do you know where to stop your bony debridement, Dr. Warner? Are you a big paprika sign guy or whatever red spice from Eastern Europe?
Yeah, that's a really good question. And I've asked a lot of people that question as well without a really clear answer. But the appearance of the bone, I think, is the most common answer of when the bone starts to appear to be healthy, for whatever that means. So bleeding bone edges, which is not always super obvious, I think can be helpful. But in general, I think the key is to be aggressive with the debridement. Any question of whether a piece of bone is viable, it's better just to debride it. We have a lot of tools to reconstruct bone, regrow bone now, and so be on the aggressive side of the debridement. I've tried some other techniques, spy angiography and things like that, but haven't been too impressed with that. So I think just the overall appearance is the best thing that I have. I don't know. You guys have any magic tools for this?
Not really, no.
Yes.
The spy thing you mentioned, and we fiddled with that for a little while. Maybe it will improve over time, but it did not seem to be helpful. At least we couldn't really understand what we're looking at because it all looked basically black. And yeah, I mean it's tough, especially I think in the mid diaphyseal area. It's like I don't know how much regular cortical bone really bleeds like that, as opposed to the metaphysis. I think maybe it's a little more reliable, but at the end of the day, you've already got a circumferential multi-centimeter defect if you end up taking a bit more on either side. I also would tend to rely on, okay, is there like real periosteal attachment versus kind of this bare ebony type appearance? I would be more prone to remove that.
Yeah, I think while Dr. Burks pulls this case up, for me, if it looks like an elephant's tusk, it's no good. But paprika can help. But sometimes you even have to take a burr, and you may not have to take the whole thing out, but you can just burr down until you get to something that's bleeding. But make sure you have the tourniquet down when you're assessing it.
So here's another case. Hopefully you guys can learn something from this, or you can tell me what I'm doing wrong. So this 35-year-old guy shot in multiple locations in his body. He's got this large open wound, seemingly kind of a high energy, high velocity type gunshot wound to this proximal leg. With the x-rays you see there, he's taken to the operating room. He's got a brachial artery injury, also with an associated plexus palsy. But he goes to the OR for bypass of his upper extremity vascular injury. And whoever was on call that night, they took that as an opportunity to debride this tibia and the soft tissue surrounding wound. And the debridement was, I would say, abruptly aggressive. These were all totally devascularized chunks of his tibia that came out. I will do this occasionally. It's for a large sort of span, thinking about how you're going to get this stabilized with an external fixator to provide any real stability with a big open wound. I kind of like this technique just as provisional fixation. I don't know if you guys have employed anything like this before.
I think it's great for 3B open wounds where you're going to be back there anyway. I don't like it if I've got to close wounds or extend incisions to do it. But if it's presented to me, I think it's a great cost-effective way to stabilize. I just wish they may have gone a little bit more medial on the plate to try to reduce this a little bit better, which may help you at definitive, but you can make adjustments when that time comes.
Yeah, I mean, this is kind of just like gross limb alignment, and
Yep.
so we we got a problem here. We already kind of touched on the feed pouch versus vac portion of this. As you guys are thinking about this, what would y'all do as, we'll call it, sort of next steps in management here?
Yeah, I think and he's revascularized. The limb is
Yeah,
revascularized.
the leg was always perfused. There was an upper extremity bypass was the issue. So
I see. Okay. Yeah, I would place the antibiotic splint spacer, um, and then I'd convert this most likely to external fixator. And then, in terms of bone defect management, I think one thing about this injury is the surface characteristic of the tibia, especially that long oblique spike of the distal segment. If you're thinking about anything bone transport and need to make a flat cut, you're going to be really removing a decent amount of bone there. So I would probably plan to do an intramedullary nail antibiotic splint spacer, and then probably come back after the flap matured in 6 to 8 weeks, and then do a bone grafting and augmentative plating.
Yeah, I
okay,
think this is for me. This is I mean, we've got to figure out with plastics. They've got to be able to cover it. And then I think it's what risk are we taking? I do think there's probably some early shared decision making with the patient. I think if you want the most reliable thing for this to be healed and them getting on back to their life at a year, you're probably thinking of some kind of retrograde transport down the line, but that's not going to happen immediately. You got to let the flap heal. If they want to roll the dice on induced membrane technique, which I think if that works, it's a home run. So even if it works 60% of the time, patients stay functional with a spacer and a rod. That's a great way for them to be very functional. But I think you're running a higher infection risk and needing to go back to square one and doing the transport. And that's what I don't think we fully know yet. But we just got to share information where we can from the studies that have been published to help the patients make a decision.
yeah, tough problem, big defect, large soft tissue defect. All that is getting dealt with. So we this is where I kind of came in, did some repeat debridements. Pretty much the whole deep posterior compartment came out. He has really no anterior compartment. His posterior and lateral compartments were okay. I went to bleeding bone, Steve, just for you. So we felt like whatever was left was viable. And then I took your advice, I guess. Did this nail cement spacer with the concept of coming back in Mascalay, and the soft tissue procedure he ended up receiving. Probably in hindsight, I bet they wish they would have done something different, because basically what they did is they took all the posterior muscles of his leg and put it on the anterior part of his leg. So, but nonetheless, the wound is covered. The interval here from the time he came into the hospital to the time he was covered and stabilized, at least semi-definitively, as you see here, was 8 days. So concerns about that, or that's just kind of the way that it is?
Yeah, I mean,
Maybe
the 8 days is what it is. I think obviously the sooner will be better. I think 7 days has been shown to be kind of a cutoff from injury to coverage. But I think, the local flap, like you mentioned, is a huge concern. This was an extensive zone of injury. As you mentioned, the anterior and I think you said deep posterior compartments were removed. And so considering the proximity of the other compartments and the likely damage that they have, using those to rotate over and cover the open wound where you're gonna have to go back for multiple procedures had some concerns. So I would have pushed pretty hard with
Yeah.
the plastic surgery team to do some sort of free tissue transfer for this to have something that's more durable and more reliable than local coverage in this injury.
Yeah, that's a good point, because it's like you're going to be going back in. It's like, well, how am I going to get there if I'm flipping up, some kind of lasagna noodle type layer of rotational flaps? So that's an excellent point. Um, So he kind of moves along, soft tissue heals. This is a picture about 3 months. Kind of resurfaced, not the most, we'll say, reliable in terms of the follow-up. At least he shows up when he wants to. Here, I'm kind of in my brain thinking, all right, we're going to move on to the next stage. Turns out he also got shot in his eyeball and needed some treatment for that. So he's like, I gotta need some eye surgery. He comes back in a couple months. So here we are, 4-ish months down the line. I personally like getting labs again here. Once again, doesn't prove anything definitively, but gives me maybe higher or lower index of suspicion in conjunction with the exam as to if this is aseptic or not. But the leg looks pretty benign. The CRP is normal, and so again, I'll just move forward here with my plan, which was Dr. Warner's plan, as it turns out. So adding a plate that was done through pretty much just kind of a limited proximal incision and screw fixation distally, as you see here, and then accessing obviously the spacer to bone graft. So took a whole bunch of iliac crest and a whole bunch of allograft to fill that defect, which was sizable. And then it comes back now. So we're about 7 months down the line. Um, Draining at this point is clearly worrisome, and so worrisome, in fact, that it's confirmatory criteria for infection. So the leg additionally is kind of swollen hot. He's got an elevated CRP. What now? What now, doctors?
I mean, I think your
I mean,
X-ray overall is I think somewhat reassuring from a bony standpoint. It looks like your graft is consolidating some, so I think that's the good news. So I would do, yeah, in your CT, it looks like your graft is consolidating some, and the fact that you don't have full consolidation is not surprising given the extent of the defect. Sometimes with these larger defects, doing two masculates is something to anticipate, which is in this case something that you would probably do. But I would still, with the draining wound, I'd do a flap elevation. I have to study the CT to see if there's any local areas of fluid collections that really target, but I would do a flap elevation, local debridement, take cultures, and then try to suppress with antibiotics.
Yeah,
yeah,
no obvious collections per se, but I don't think that doesn't mean it's not infected.
I would probably, I think this is going to be infected. I would probably lean towards getting the metal out and moving him towards rings, because I think you're likely in a biofilm situation here with the exposed metal. But I do think you're progressing towards consolidation. So I think the biofilm host need to come out and be replaced with something that's much less of a biofilm host. Is I think you're winning on the trend towards getting bony healing right now.
Josh, does the patient kind of intermittent follow-up uh, have any concern with using rings? I know people will say that unreliable patients using rings can be a little bit tricky, and any
If
consideration
he's
for that.
Well,
And
it's just if he, I mean, I think the antibiotic nail here is good, but I think the rotational control with it, so there are ways to make them more rotationally controlled. I think if you're not asking, I think unreliable patients having to do turns or corrections or lengthenings without automatic struts is a real problem. I think if it's just wearing it and saying, don't touch this, don't mess with it, I think it's much less, but it's something you have to consider.
Yeah. So again, just to reorient you, we're about a year and 2 months out from his original injury. This is what I did. Re the canal, removed all the previous internal fixation as you guys suggested. The leg kind of seemed stiff and stable enough, but good points, Dr. Gary, as far as providing opportunity for some more stability. So we kind of go along. It comes back 6 weeks after that. Okay, I'm trying to convince myself that, geez, man, is this healing? Uh, I've seen that kind of here and there. Gotten lucky. It's like get rid of the infection, and things continue to progress as far as the healing is concerned, even without something totally stable internally here. So I'm kind of trying to talk myself into just leaving it alone. He's getting around using a cane, semi-functional. But as luck would have it, he eventually comes back. He's got
Ooh, and he broke the nail. Oh,
yeah, deformity of his leg. Like it's a flexible enough deformity that he's trying to describe why his leg is shaped like a banana. I'm like, well, I think I understand why. Um, so he's kind of sort of compliant with the antibiotics, but off again, on again, if you will. Check the labs; they all look pretty promising. So it's in the leg itself had a benign type appearance. So I thought, geez, this almost seems like a quasi hypertrophic non-union. Maybe I should just exchange nail it and compress it. Here's a CAT scan. I don't know. Some of the stuff in the canal, is that just not consolidated bone graft? It's a little more promising on the posterior cortex. So at any rate, we go back, take out the antibiotic rod. This is what I found useful. Just retrograde long Steinman pin and just tap it back up after spending about 45 minutes with laparoscopic graspers that did absolutely nothing. So if you guys ever
the
run
one
into
other
this is what I would suggest from the jump.
other thing to try Moreland's. So if you get the Moreland reverse curettes, I've used that to get the broken antibiotic rod out like that.
Culture's negative. Before putting the nail in, we took some, uh, calcium sulfate with impregnated antibiotics, injected that into the canal, kind of provided a quasi antibiotic rod type situation. So this is, I think this was a 12 or 13 nail. I don't know. You can see we tried to compress as well with the bent screw in the dynamic position there. Uh, Everything was going great. Thought we were good, and then we weren't good. So he comes back. He's got this, wound that looks like it's about to burst. It hasn't quite done that, but it's, it looks like a butterfly in a chrysalis here. It's just about to emerge. And he's got more pain. Labs are up. I feel like we've made zero progress over this entire time period, but here we
Bone
are.
looks
I
more
don't know if
solid.
you.
Yeah,
Looks more
you're
like
progressing
Davcia
with healing
bone.
for sure.
All right. Well, again, that's kind of what I thought. Somebody ordered a SPECT CT, as it turns out. I think he was on a medicine service. That's
It's
why
hot.
this
It's hot.
happened. Yeah, I mean, but like, I don't know, what does that tell me to do
Like,
other than debride his canal and take out the metal and kind of go back? But in hindsight, I guess I have some questions about what to do here. I'll just move it forward. So, of course, uh, to clarify, we talked about amputation now at this point, not as like kind of the go-to option, but a option entering the discussion. We debrided it, did the exact same thing. He got a more patient-friendly version of antibiotic treatment. And again, to reference, we're over 2 years out now. And I'm again hoping this thing's going to heal. Comes back 5 months later, not healed, broken rod, same
Mm.
story. Labs are normal. So, definition of insanity. We're just doing the same thing one more time. It's going to work or not. We'll have to wait for next year's webinar to really find out. But we're over 3 years out now, and I guess in hindsight, um, perhaps some things I should have done differently. The whole Mascalay pursuit may have been flawed from the beginning, or maybe I should have gotten off that and just said, "Oh, I'm just going to resect everything. All this bone graft's going to come out. We're just going to start over, and it's going to be a bone transport where the infection is going to burn out in the fires of the regenerate." But very tough case, very challenging patient, just from kind of he's frustrated, I'm frustrated. We'll see. I don't know. But this, I don't know, they can just underscores the difficulty with dealing with these infections. And every once in a while, I have to provide a copy of my partner's best-selling book, Living with Infection, because I feel like sometimes that's just what we have.
fantastic.
The pus may never go away.
Well, again, the amputation talk starts to become more real as time goes on. But this is tough because we're talking about above knee amputation in this guy's case. That's not a great option.
Yeah, that is for sure. And I think that's a different, but I see people we think were cleared for pus and they come back 2, 3 years later when they've had no sign and have no metal in them. But that's, I think, part of it. Well, thank you all for the cases tonight. I think those are great examples of different ways to deal with things. And I don't think we fully have the answers yet, but hopefully we get more answers in the years to come with some of these studies. Upcoming events for AO on July 28th, Module 4 on humeral shaft from non-op to plates and nails will start, and that will be the same format with webinar, then journal club, and then a fireside chat. Also know that the AO Trauma North America event in Tempe, Arizona, November 6th and 7th is coming for a deformity malunion non-union course. So we want to thank you all for joining tonight and taking the time away from your families. Thank you, Dr. Warner and Burks. Thanks to the AO staff for putting this on. And this will be recorded and available if folks want to look at this in the future. Thank you all so much.